Hi guys, welcome. We are going to be talking about pre and post ductal saturation. So, pre ductal saturation is the saturation that's measured before the ductus arteriosus, and post ductal saturation is the saturation that's measured after the ductus arteriosus. When we are talking about the flow of blood, if we are starting from the left ventricle and the blood is moving to the aorta, then the pre-ductal saturation is any saturation that occurs before the ductus arteriosus or the patent ductus arteriosus. So pre-ductal saturation, we measure it from the right hand or the right earlobe, and post-ductal saturation we measure it from the lower limbs. So I'm going to start by explaining the anatomy so that we can understand where the pre-ductal saturation comes in and why it is important for us in certain times to measure pre and post ductal saturation. So I'll start by explaining fetal circulation. In fetal circulation, this is the placenta, and there is a cord connecting the placenta to the baby, and in the cord there are two arteries and one vein. So the artery carries oxygenated, the arteries carry directly blood to the placenta, and while the artery carries the vein carries oxygenated blood to the baby. So this is the vein in red, which is carrying oxygenated blood to the baby, and it bypasses the liver, then it goes into the and eventually into the right atrium. So blood in the right atrium, because of fetal circulation, pressure on the right side is higher than on the left. Most of the blood is sent to the left atrium, and some of the blood is then pumped to the right ventricle, and then it goes into the pulmonary artery. But because there's so much resistance in the lungs, some of the blood is going to be shunted to the descending aorta through the ductus arteriosus. So you find that there's minimal blood that goes to the lungs, but this blood will then be returned to the body. Actually, when it returns through the pulmonary vein or the systemic circulation. Then you find that in fetal circulation, blood that's from the left ventricle is oxygenated blood, and this blood is then pumped to the body, and some of the blood continues through the aorta, into the abdominal aorta, and into the internal iliac artery, which then gives branches to two umbilical arteries, okay, which then move to the placenta. So if at birth we expect the lungs with the first cry to expand, and we expect vasodilation, and the pressure in the lungs decreases. So what that means is that the pressure on the right and the pressure on the left equilibrates, and so there's no more shunting of blood from the right atrium to the left atrium, and there's no more shunting of blood from the pulmonary artery into the descending aorta. So what that does is that you find that now the blood will now be flowing, and also at birth there's we cut the cord and clamp it. So what happens is that blood will now be flowing from the right ventricle. Blood will flow to the lungs, then it's oxygenated in the lungs, and it comes back to the left atrium, then into the left ventricle, then into the systemic circulation, then back to the right atrium, then into the lungs, and it continues like that. So there are certain conditions where the transition from fetal circulation to extrauterine circulation fails to occur. And if that occurs, it's because the lungs may fail to expand at birth. And the causes of that, we're going to talk about that. But I want to explain to you, if that happens, it means that this patient remains with higher pressures on the right side. And what that means is that blood will be shunted through the ductus arteriosus from the pulmonary artery to the descending aorta. Okay, so there will be also shunting of blood through the foramen ovale. But what we can measure is significant differences in the saturation of blood that's before the ductus arteriosus for this aorta, and that's which is above after the ductus arteriosus. So if I'm talking about the anatomy of the aorta has got an ascending aorta, an arc of aorta, descending aorta, and then abdominal aorta. So the aorta gets branched to the right brachiocephalic arteries, which then divides into the left common carotid and the right common carotid and the right subclavian. Then we have the left common carotid and the left subclavian branches. Then after that, that's where the ductus arteriosus is. So if it's persistent, it can be a pattern ductus arteriosus. But after birth, it usually forms the ligamentum arteriosus. Okay, so if the fetal circulation persists, it means that there is pressure is higher in pulmonary artery compared to the aorta. So blood is sent from the pulmonary artery into the aorta. And what this means is that oxygenated blood that's in the aorta is being pumped to the rest of the body as oxygenated blood. But as soon as it comes to the point where it meets the ductus arteriosus, the pattern ductus arteriosus, deoxygenated blood is coming in, and this deoxygenated blood is mixing with oxygenated blood. So the saturation of blood post-ductal, after this ductal, the lower limbs and every other organ that's perfused after the ductus arteriosus, we have a lower saturation compared to the organs that are pre-ductal. Okay, so if you're taking saturation of the right arm or the right earlobe, it should be higher than the saturation of the lower limbs. So conditions that cause this persistent fetal circulation or persistent pulmonary hypertension and makes the lungs to fail to expand at birth include meconium aspiration syndrome, pneumothorax, pneumonia, sepsis. It can be primary, it can just occur with no specific cause, or it could be prenatal closure of the ductus arteriosus. Then drugs like non-steroidal anti-inflammatory drugs can also cause vasoconstriction of the vessels in the lungs and make the the pressure in the lungs to remain high. Then failure of development of the lungs can also make them to remain at high pressure. And this occurs in conditions where there is oligohydramnios, especially secondary to posterior lateral valves in males, or it could be due to amniotic fluid being pushed out of the lungs, as occurs with congenital diaphragmatic hernia. Another cause of difference in the saturation, pre and post ductal saturation, occurs later on in life. But in neonatal period, the patient may be having equal saturations. But if there is reversal of flow, because later on the pressure in the lungs is increased, as occurs with Eisenmenger syndrome, this can also lead to flow of blood from the pulmonary artery into the aorta. And for this to occur with Eisenmenger syndrome, it is when the ductus arteriosus is patent, and then the pressure in the lungs increases because of Eisenmenger syndrome, eventually causing right to left shunting. And those two conditions, if you measure the saturation on the right hand, you will find that it will be 10% higher than the saturation of the lower limbs. And any difference of 10% or more between the saturation of the right arm and the lower limbs is significant difference between pre and post ductal saturation. And that shows that there is flow of blood from the pulmonary artery to the descending aorta. So there is right to left shunting of blood through the ductus, the patent ductus arteriosus. That's the significance of measuring pre and post ductal saturation. Thank you.